chest tubes, principles, techniques, and pitfalls. Part 1 of this talk will describe the evolution of pleural drainage from the early attempts until today and will help us understand the basis of the physiology behind them. In ancient times, the lung and the pleural space were often affected by tuberculosis, with formation of debilitating chronic cavities, effusions, and empyemas. Bronchiectasis follow the destruction of lung parenchyma and bronchi and add to the chronicity of the disease and to the productive cough or to severe bleeding as demonstrated in this specimen. Before the advent of antibiotics and chest tube drainage, it was not unusual to see patients in whom a chronic pleural and lung infection drained spontaneously outside the chest cavity, the so-called empyema necessitans. The classic symptoms of active TB are chronic cough, blood-tinged sputum, fever, night sweats, and weight loss, which leads to the so-called consumption. Most of these patients eventually died after a miserable and debilitating illness. Also common in the past were non-lethal chest wounds that produce empyema and bronchopleural fistula. Many of them created chronic problems to the affected people. In antiquity, natural selection was very high. Penetrating trauma or incision in the chest were often lethal due to the collapse of the lung and to the inability to manage pneumothorax and infections. Doctors were surgeons by necessity or convenience. They had little training and no concept of asepsis. They performed different operations but could not make an incision in the chest unless in an abscess cavity isolated from the pleural space. They did not have any radiologic imaging. Imagine the dilemma of those doctors who wanted to help but were just a step from being labeled as quacks. Ancient doctors didn't know that the pleural space has a negative pressure, which means less than ambient pressure, which is 1 atmosphere or 760 millimeters of mercury. The negative pressure is created by the natural recoil tendency of the elastic lung and by the respiratory muscles, also by the surface tension holding the visceral and parietal pleura together. This negative pressure would suck air inside the chest through a pleural opening. Therefore remember that during the cycles of breathing, at rest, during inspiration, and during expiration, the intrapleural pressure is usually below ambient pressure, which means below 760 millimeters of mercury, and always below the intrapulmonary pressure. All this was unknown to ancient doctors. Hippocrates deserves the title of father of medicine and that of the first thoracic surgeon for his observation on tuberculosis and the description of incision and open drainage of tuberculosis effusions. These operations were successful as long as the incision opened the abscess cavity without entering the pleural space. Probably more attempts failed than succeeded. Hippocrates taught in the island of Kos in Greece. Aurelius Celsus wrote extensively on the character of inflammation and on chest empyemas. Famous was his dictum that where the pus is, evacuated. Please do not confuse him with the Swedish astronomer Anders Celsius, who invented the Celsius scale, unit of measurement for temperature. He lived between 1701 and 1744. Celsius also wrote on rib resection and described the use of metal trocars. As previously said, these therapeutic interventions on the chest had some positive results only in patients who already had extensive pleural adhesions. Only in the early 1800s the pneumothorax was extensively described by Itard and his teacher René Laennec. Finally, in 1867, Thomas Hillier, trying to prevent a pneumothorax, opened empyema underwater in a warm bath. This was a totally revolutionary concept. Unfortunately, he died at age 38 from tuberculosis that he likely contracted from his patients. A nice description of this ingenious idea exists in the British Medical Journal, August 3, 1867. In 1875, Playfair, in treating an empyema, solved the problem of pneumothorax by continuous subaqueous drainage of the pleural space. He created what we call tube thoracostomy with a water seal. Without the water seal, the negative intrathoracic pressure would suck air inside the chest and the lung would collapse. Also, this great step in the treatment of empyema was reported in the British Medical Journal in January 1875. The principles applied here are: 1. The column of fluid creates a vacuum behind and pulls down more fluid. 2. The distal end of the tube needs to be kept underwater, and therefore the underwater drainage needs to stay below the level of the chest. At about the same time, Croswell-Hewitt developed a continuous chest drainage, using a red rubber catheter in an antiseptic jar to drain an empyema thoracis. The Hewitt drainage used a single bottle with water or disinfectant to create a water seal. However, since the level of the fluid in the bottle raised with the drainage of fluid from the pleura, there was an increasing resistance to the drainage itself. To better understand this concept, try to suck fluid or to blow air in a bottle first at the surface, then close to the bottom. The latter requires more effort. In 1880, Carlo Forlanini from Italy introduced the concept that TB cavities heal faster if collapsed. In order to collapse them, he created the artificial pneumothorax. The concept of negative intrathoracic pressure and the collapse of the lung in absence of it started to become clearer. Since the lung does not collapse if the pleural is open in the presence of pleural adhesions, the technique of creating pleural adhesion adjacent to a lung process was eventually developed by placing foreign materials in the extrapleural space. The lethal pandemic of Group A streptococcal pneumonia in 1917 and 1918 was associated with a rapid and early accumulation of empyema fluid. 21 million deaths were the catalyst for the renewed interest and study of empyema. The use of open drainage to manage this illness resulted in high immediate mortality rate, probably because patients developed a pneumothorax. Those hospitals, instead, that used the Hewitt underwater drainage achieved much better survival. Eva Graham was appointed by the Surgeon General to the Empyema Commission of the U.S. Army and prompted research which led to the modern understanding of pulmonary and pleural physiology and mechanics and paved the way for most of the recent advances in thoracic surgery. The use of chest tubes and surgical thoracotomies became routine in the battlefields of World War II and Korea. From this research it was discovered that the intrapleural pressure is negative between -3 to -8 centimeters of water, below ambient pressure. If air is introduced in the pleural space, the lung will collapse due to the richness in elastic fibers. The intrapleural pressure changes with the breathing phases. Normal intrapleural pressure are -6 to -8 centimeters of water during inspiration and -3 to -4 centimeters of water during expiration. During forced inspiration, like with the closed glottis or blocked endotracheal tube that leads to asphyxia, the intrapleural pressure may exceed -50 centimeters of water, while during forced expiration, like during coughing, may reach +70 centimeters of water. The drainage system improved when Robinson in 1910 added suction to the bottle and when Lilienthal used 2 bottles instead of 1. This way, the level of the water seal did not change with the amount of drainage. How much suction should we apply to the pleura? The most common suction used today is -20 centimeters of water. This evolved mainly from trial and error. Initially, a commonly used 1-gallon glass bottle was filled to near where the bottle tapered at its neck. The end of the vent tube was then positioned about 2 centimeters from the bottom of the bottle, so that the tube was submerged about 20 centimeters, which in turn controlled the pressure of the vacuum in the system. This works most of the time by creating a negative intrapleural pressure of about -6 to -8. In 1952, Howe introduced a third bottle to regulate the amount of suction by moving the tube in communication with the ambient air up and down in the water. This arrangement serves as the basis for almost all thoracic drainage systems in use today. Here is clearly visible a 3-bottle system. On the right, the suction or manometer bottle with the immersed tube in communication with the ambient air. This tube can slide up and down to regulate the suction. In the middle, the water seal bottle, and on the left, the collecting bottle. Therefore, it took almost 80 years to develop a modern chest drainage system. Here you can see the three functions of collecting, water seal, and suction in 1, 2, or 3 bottles. And this is the way one of the many modern chest drainage units, otherwise called CDU, looks like. I hope you enjoyed, and I hope I will meet you also in part 2 and 3 for more on the topic of chest tubes, principles, techniques, and pitfalls. Part 2 of this talk is about indications and technique of chest tube insertion. Most of the indication for the placement of a chest tube is the presence in the pleural space of a significant amount of air, called pneumothorax, or fluid, called hydro, or chylo, or hemothorax. Sometimes a chest tube is inserted preventively in critically ill patients when mechanically ventilated with very high mean airway pressures. Caution needs to be used in patients with bleeding disorders. The pneumothorax can be spontaneous, either primary or secondary to bullae and/or blebs, or can be traumatic or iatrogenic. The latter is usually produced by insertion of central venous line or by lung biopsies. It is proper to treat them when significant for the patient's condition or if increasing in volume into separate chest X-rays. During treatment of a trauma, they are often inserted on physical exam only or clinical presentation. This chest X-ray demonstrates the presence of a large right pneumothorax with lung collapse and minimal mediastinal shift toward the left. This drawing illustrates the difference between a bulla and a bleb. The bulla forms from progressive rupture and coalescence of numerous intraparenchymal alveoli in the lung itself, while the bleb is due to rupture of a subpleural alveolus. Here are radiologic, thoracoscopic, and histologic images of bullae and blebs. This is an example of an iatrogenic pneumothorax created during the insertion of a needle in the left subclavian vein for pacemaker placement. The chest computerized tomography, commonly abbreviated CT, with and without contrast, is the most common imaging procedure used for the study of lung pathologies. The axial view is obtained cutting the body in slices, head to toes, and viewing them from the feet, like the observer of the body of Christ in this painting of the Italian Renaissance. This chest shows a common procedure done for histologic diagnosis of lung nodule, the so-called CT-guided lung biopsy. It has 10% incidence of iatrogenic pneumothoraces, which are usually treated by insertion of a catheter, a small chest tube, in the affected pleural space. A Heimlich valve can be connected to the catheter after the lung is expanded, and the catheter will be removed as an inpatient or outpatient procedure. The incidence of iatrogenic pneumothorax from CT-guided needle biopsy is more common when big needles are used and/or in patients with emphysema, as in this patient. The radiologic signs of emphysema are flattened diaphragms, increased intercostal spaces, and hyperinflation of the lungs, the so-called barrel chest. Pneumothorax can be bilateral and usually from trauma. This chest CT also shows mediastinal emphysema in addition to bilateral pneumothoraces. Mediastinal emphysema develops from rupture of alveoli in the parenchyma adjacent to the hilum of the lung. Through the root of the lung, the air spreads to the mediastinum, surrounding the large vessels and bronchi, and can enter the pericardium, so-called pneumopericardium. In a tension pneumothorax, the intrapleural pressure, instead of being negative as in normal people, or equal to atmospheric pressure as in simple pneumothorax, is positive for a ball-valve mechanism. This means that progressively more air accumulates in the pleural space and pushes the mediastinum to the opposite side. This mediastinal shift produces distortion and compression of the vena cava and of the trachea, which is visibly deviated to the opposite side of the tension pneumothorax. The reduced venous return produces circulatory collapse. The circulatory collapse in the presence of tracheal deviation and hyperresonance of the affected hemothorax are enough to make a diagnosis. A chest X-ray should not be necessary to confirm the suspected diagnosis, since it would delay the treatment of this life-threatening emergency. The term hydropneumothorax implies the presence of air and fluid level in the pleural space. The chest X-ray and chest CT in this patient show a straight line that changes with different decubitus. Sometimes a wrong diagnosis of pneumothorax is made on a chest X-ray for different non-related conditions. Skin fold that overlap the lung field can be misinterpreted as pneumothorax on a chest X-ray. A chest CT would clarify the diagnosis. Also, giant bulle can be erroneously interpreted as pneumothorax on a chest X-ray and a chest CT. However, the presence of compressed adjacent lung and the location in the upper lobes may help clarifying the diagnosis. Less commonly, the lack of breast tissue following a mastectomy produces a hyperlucency which could be interpreted erroneously as a pneumothorax on a chest X-ray. In the pediatric population, some conditions can be confused with a pneumothorax on a chest X-ray. A pneumatocoel is a giant intrapulmonary air-filled cavity, resulted more commonly from staphylococcal necrotizing pneumonia. Also, congenital cystic lung malformations may mimic a pneumothorax on a chest X-ray. Pleural effusions are the other common indication for the placement of a chest tube. Their nature can vary widely. It is important to decide if the amount of the fluid justifies the patient's symptoms and whether it indicates the necessity of a drainage. If drained, the fluid needs to be sent to the laboratory for the differential diagnosis between transudate and exudate. The ratio between the serum and pleural fluid LDH is the most reliable single parameter for the diagnosis. If the fluid looks cloudy, It needs to be sent for culture and sensitivity. Malignant effusions are usually indicative of a late stage of a cancer. They tend to recur and are treated preferentially with the talc pleuradhesis. Large, simple effusions are usually drained by a single chest tube, while multiple loculated parapneumonic effusions may need several drainages, enzymes for fibrinolysis, or a pleural decortication. An empyema usually requires a decortication to remove the lining of the infected cavity and re-expand the lung. A chest tube placed before surgery may reduce the toxic status and aid with the perioperative management. Sometimes the effusions develop in the interlobar fissures and don't communicate with the remaining pleural space. Their appearance is characteristic in the lateral chest X-ray projections. After a pneumonectomy, a slow accumulation of fluid in the pleura is desired to prevent acute mediastinal shift. Some surgeons routinely use a balanced drainage without suction, with or without clamping of the tube to regulate the amount of mediastinal shift. Balanced drainage was introduced in the mid-1970s and provides an intrapleural pressure of approximately -6 to -8 cm of water. Suction is rarely used, mainly for empyema present before the pneumonectomy. Other surgeons prefer no drainage. Most important, monitor the patient clinically and with frequent chest X-rays. After a pneumonectomy, the empty pleural space fills with plasma fluid. The late appearance of an air fluid level in a previously totally opacified pleural space is usually diagnostic of a bronchopleural fistula and is an indication for the placement of a chest tube in addition to placing the patient on the same decubitus of the affected side to prevent aspiration through the bronchopleural fistula in the contralateral healthy lung. A relative contraindication to a chest tube are the tuberculosis effusions. These are better treated with a medical therapy. The insertion of a chest tube may create a superimposed purulent infection. A rare complication of nasogastric tube placement is depicted in this chest X-ray. The nasogastric tube goes down the trachea instead of the esophagus, then into one of the right lower lobe basilar segments. Then, being pushed farther, the middle portion coils in the left mainstem bronchus. Infusion of tube feeds floods the right lower lobe, giving the wrong image of a pleural effusion. Atelectasis of the right middle lobe can give, on superficial view of the chest X-ray, postero-anterior projection, the wrong impression of a right paracardiac effusion. The lateral view will clear the confusion. This chest X-ray shows the typical appearance of a lung abscess with an air fluid level, not to be confused with an effusion. As a consequence of trauma, the diaphragm may rupture, more commonly on the left side. The negative intrathoracic pressure favors the migration of viscera in the chest, creating opacity often confused with effusions. In the two chest X-ray presented, their fluid level are intragastric. Pericardial cysts are more common on the right side and can be large. Sometimes they are confused with loculated effusion. If small, most of the time they don't need any treatment. As a consequence of trauma, rib can fracture and the intercostal arteries can be lacerated and bleed in the extrapleural space as long as the pleura is intact. The crescent moon appearance is typical of an extrapleural hematoma. The pressure of the hematoma tends to reduce the bleeding. The ideal chest tube needs to be soft and needs to retain its original shape at the body temperature. It should be resistant to the formation of blood or fibrin clots. The first chest tubes were made out of caoutchouc, later out of red rubber tubes, and finally out of PVC, plastic or silicone. Chest tubes can be straight or angled or shaped with a pigtail at the end. They can have an inner trocar for insertion, so-called stylet. Today's chest tubes are made out of PVC or silicone. They are heparin bonded to reduce the formation of clots. They have a radiopaque stripe to show the intrathoracic position and the location of the sentinel hole. The sentinel hole is the hole in the chest tube wall closer to the skin entrance. It needs to always stay inside the chest to avoid the entrance of air and collapse of the lung, so-called pneumothorax. The larger sizes are relatively kink resistant. They have a flare end to receive the connector to the drainage unit. Several million chest tubes are used every day in the United States. Some chest tubes come with an inner trocar. They have fewer holes on the tip. More holes can be added on the radiopaque line with a surgical blade number 10 or similar. Their use minimizes the skin incision and the subcutaneous tract because the rigidity offered by the stylet and the sharp tip allow to penetrate the subcutaneous tissue and the intercostal muscle without the need for a dissection once the skin incision has been made. They require a firm two-hand grip and the retraction of the stylet once the operator feels that the tip has penetrated through the pleura. They are very safe in expert hands. They are also very safe when the chest X-ray demonstrates the lung away from the chest wall due to interposed air or fluid. They are best for apical drainage in the second intercostal space in the mid-clavicular line because they have fewer holes than a regular non-trocar chest tube, which would have the sentinel hole outside the skin. There are also pigtail catheters with trocar. The Denver pleuroperitoneal shunt has an integrated, compressible, one-way valve designed to move pleural fluid into the abdomen, especially for palliation in patients with malignant pleural effusion and or persistent chylothorax. 15% or more of the shunts become occluded with time. The resistance to the flow of air or fluid inside the chest tube is calculated by the Fanin equation. Small chest tubes, usually less than 24 French, have higher tendency to occlude. Chest tubes larger than 32 French are usually not necessary and create discomfort to the patient by compressing the intercostal nerve. The number and position of the chest tubes need to be tailored to the patient needs and to the nature and position of the drainage. They should be positioned near the area of surgery where air or fluid need to be drained. The chest tubes are usually inserted in the anterior axillary line for patient comfort. The chest wall tract created with an instrument will determine the direction of the tube inside the chest. The tip of the chest tube should be preferentially at the apex of the chest for drainage of air and along the diaphragm for the drainage of fluids. Therefore, chest tubes are usually inserted into the 3rd to 6th intercostal space in the anterior or mid-axillary line and then directed cephalad for the evacuation of free air or posteriorly for the evacuation of fluid. For loculated air or fluid at the apex of the chest tube or catheter is inserted into the 2nd intercostal space in the anterior mid-clavicular line. It is better to cover the skin hole with a Vaseline gauze to prevent air to enter the chest between the skin and the chest tube. After cardiac surgery, straight and/or angled tubes are used to drain the area behind the sternum, the pericardium, and, if necessary, an open pleural space. Cardiac tamponade is possible even in presence of well-placed chest tubes. Stripping the tube away from the patient to reduce blockage is discouraged, since it may increase the bleeding by generating a negative pressure in excess of -400 cm of water. Tapping the tube with a clamp to mobilize clots is an efficient way to prevent tube's blockage. Simple congenital cardiovascular procedure done through small thoracotomies in babies can be performed without the use of chest tubes. In fact, small chest tubes have a great tendency to clot, kink, and become non-functional. Emergency chest tubes are often inserted in the trauma room or in an ambulance when indicated to save the patient's life. Often, no previous chest X-ray is available. Finger exploration of the chest cavity is indicated upon entering the chest cavity to rule out lung adhesions. They tend to have high complication rate. This is the typical scenario of chest tube in the emergency setting. However, there is no need to explore the chest cavity with a finger if a previous chest X-ray has already shown a large amount of air or fluid between the lung and the chest wall. Insertion of a finger in these cases only increases the risk of carrying skin bacteria inside the chest. A tension pneumothorax represents a life-endangering situation. The diagnosis should be clinical and not based on a chest X-ray. The intervention should be immediate by inserting a decompressing needle in the 2nd or 3rd intercostal space in the mid-clavicular line on the opposite side to the tracheal deviation. If the room is quiet, a hiss sound can be heard. Listen for the hiss sound. Elective chest tubes need a good quality chest X-ray, strict sterile technique including a mask, hat, gown, gloves, a good skin preparation and sterile drapes, an assistant for help, oxygen for the patient, and also a good local anesthesia. It is important to use a 22 gauge needle finder to precisely localize the air or fluid. Small or large bore chest tubes, trocar or non-trocar chest tubes can be used. A small incision and tract are recommended. Minimal complication rate is expected. This is the link to a nice video about chest tube insertion. It is proprietary of New England Journal of Medicine. Therefore, it is necessary to subscribe. Your medical library could easily obtain it for you for free. A loculated fluid collection can be drained at the bedside based on a chest X-ray and clinical findings. It can also be drained by the interventional radiologist with the help of the CT scanner. Atherogenic complications of chest tubes insertion are still possible as a result of a poor technique. They are represented by pain, a non-functional chest tube, or damage to intrathoracic and/or intra-abdominal vessel and organs. Damage to intrathoracic and intra-abdominal organs is possible if the chest tube is advanced forcefully and against resistance. If any resistance is encountered, the chest tube should be pulled back 1 or 2 centimeters. The most common complication is empyema, that is an infection of the pleural space. An uncommon complication is re-expansion pulmonary edema of the lung that has been collapsed for several days. For this reason, it is recommended to drain slowly large chronic effusions. We have encountered a rare complication after bilateral bullectomy done through a sternotomy approach. The chest tube at surgery were inserted in the subxiphoid area and the patient developed an infection of the xiphoid cartilage, possibly as a result of a highly colonized lung. Due to this, in this type of patient with a high number of bacteria in their lungs, we now rather insert the chest tubes in the intercostal space, since the intercostal muscle has better blood supply. Contrary to common belief, the skin suture at the base of the chest tube does not reliably hold the chest tube in place, since, after a few days, it tends to cut through the skin due to tension and ischemia of the skin. The picture shows a chest tube lying in the bed outside the patient who developed a pneumothorax. Therefore, we rely on a large tape to hold the chest tube in place. Normally, 2 heavy silk sutures are placed before chest tube insertion. One simple suture outside the skin incision, which is tied firmly in order to make a waist on the chest tube, and a second vertical mattress suture in the center of the skin incision, to be tied after the chest tube has been removed. As we said, the silk suture by itself is not enough to hold the chest tube in place. Therefore, several centimeters of a large 3-inch tape are firmly placed on the skin and across the chest tube, making a mesentery around the tube. This will hold the chest tube in place even if traction is applied to the chest tube during patient movements. Since sweat can make the tape loose, it needs to be checked every day during rounds and replaced if necessary. The use of suction or only water seal is based on the indication for the chest tube and the operator preference. The chest tube itself may fail to expand the lung if there is an intrabronchial obstruction, often caused by thick secretions. The patient needs to cough it out, or the secretion have to be suctioned. Bronchoscopy is indicated in some patients who cannot cough adequately and present with a bronchial obstruction. Every patient should cough and walk several times a day when able. This is a source of debate. My opinion is that a chest tube should not be clamped under ordinary circumstances. Some people clamp the chest tube for hours in order to detect very small air leaks. This is not necessary since the falling negative pressure in the collecting chamber on water seal would indicate so. Furthermore, accumulation of undrained air in the pleural space will detach progressively more lung from the chest wall, making futile the previous attempt to eliminate the pleural space. The chest tube and the collecting chamber are a closed system to preserve sterility. Occasionally, under strict sterile conditions, a chest tube can be disconnected from the drainage system to aspirate clots, or a needle can be inserted on the wall of the tube, cleaned with chlorhexidine, to inject sclerosing agent and lidocaine for the purpose of obtaining pleurodesis. The fluid should stay inside the chest cavity for 1 or 2 hours, and the tube should not be clamped, but looped on an IV pole. This way the fluid will not drain, but the air can escape from the pleural space into the drainage system. The rigid connectors join the chest tube itself to the drainage system, the CDU. If Y-shaped, they allow to connect to chest tube to a single drainage unit. I hope you will meet me again in the part 3 of this talk, where we will talk about the chest drainage unit, otherwise called CDU. Thank you. Part 3 of this talk is about the chest drainage unit, also abbreviated as CDU. This is the collecting chamber where the air or fluid drainage from the chest will go. From this unit we can get very valuable information about the patient's chest physiology. Here on the left we see the 3 barrels that constitute a complete pleural drainage unit. They are the collection barrel on the very left, connecting to the chest tube that comes from the patient. The water seal barrel in the middle that transmit the suction but prevent air to go back to the pleural space. And finally, on the right, the suction control barrel, which is connected to the suction device or to the wall suction and has a partially immersed tube which keeps the suction constant by allowing air into the barrel when the suction is excessive. This 3 glass barrel system is quite inexpensive, is reusable, and is still used today in underdeveloped countries or in hospitals that have budget constraints. On the right side of the drawing, you can see the same 3 barrel system in one single plastic unit. The 3 chambers are still communicating with each other inside the unit. The picture illustrates 3 different CDUs. One on the left has a dry suction system, while 2 on the right have a wet suction system, since the suction chamber and the suction regulator are filled with water. Being fitted with valves and not water, the dry system on the left is considered today by many the safest and ideal for use when the patient has to be moved often. When the patient is not walking, the floor stand needs to be in the open position, perpendicular to the CDU, and taped to the floor to reduce the chance to be flipped over. In patients who have a large hemothorax, usually from trauma, it is possible to collect the drained blood and retransfuse to the patient. The CDU comes in a sterile package that can be opened on the operating table. The dry suction type CDU is shown in the picture. It has on the right 3 graduated columns or communicating collecting chambers which receive the drainage from the patient. Up to 2000 milliliters of fluid can be collected before the unit needs to be replaced. The 4th column from the right is graduated from +2 to -20 centimeters of water, a function like a water manometer by showing the intrapleural pressure and its oscillations. The pleural pressure and physiology are better observed when the CDU is off suction. The section on the far left has, on the bottom, the water-sealed chamber and, on the top, the suction regulator, here covered by an instruction plate, with its rotary dial on the left upper side of the CDU. On top of the CDU there is an automatic and a manual high negativity vent which release the high negative pressure and lower the column of water in the pleural pressure indicator chamber. A positive pressure protection valve is also present, which prevents the formation of a tension pneumothorax in case the suction system gets obstructed. Also visible on the top of the CDU is the inline connector and the blue sliding clamp. When changing CDU or taking a sample of the drainage is necessary, always clamp the tube on the patient's side before disconnecting the inline connector, then reconnect with an audible click and reopen the sliding clamp. The system comes with an empty water-sealed chamber and a 45 milliliter pre-filled normal saline vial in the back of the unit. The vial is emptied through the suction port into the water-sealed chamber, and the normal saline level reaches the 2.0 centimeter mark when off suction. The wall suction is then applied in excess of -80 millimeters of mercury from the wall suction. This suction is not directly transmitted to the chest tube and the pleura. Instead, a suction regulator in the CDU is set by the factory to -20 centimeters of water. It can be regulated from -10 to -40 centimeters of water, with this rotary dial on the left upper side of the CDU, as decided by the responsible physician. The level of normal saline in the water-sealed chamber needs to be kept at 2.0 centimeter when off suction. The level needs to be checked daily when off suction, since large air leaks may accelerate the evaporation of the fluid. A level of less than 2 centimeters may let air enter the water-sealed chamber and be erroneously interpreted as an air leak. When the CDU is full or broken and needs to be changed, before disconnecting the CDU, the chest tube needs to be temporarily clamped to the patient in order to prevent a pneumothorax. Otherwise, the chest tube and the tube connecting to the CDU should be left open at all times. To repeat, this is the CDU out of the sterile package with an empty water-sealed chamber. Instead, this is a CDU that has the normal saline in the water-sealed chamber up to a proper level of 2.0 centimeters. The CDU shows a large amount of air bubbling in the water-sealed chamber. If the chest tube is properly positioned and the system is intact, this bubble of air usually comes from an air leak in the chest cavity. The water-sealed chamber has a graduated air leak monitor to estimate the degree of the air leak. Grade 1, 2 are very common and usually resolve in short time. Grade 4 or 5 indicate a large air leak, or that the chest is still open, or a problem in the system, like for instance a disconnected chest tube, or a low level of normal saline in the water-sealed chamber. There is a need for suction, usually from the wall. The factory recommends suction in excess of minus 80 mm of mercury. The factory preselects the CDU suction regulator dial to minus 20 cm of water. This is the most common setting and came from trial and error. The only indication that there is enough suction in the CDU is the expansion of the red bellows, as indicated on the right. The bellows must reach and pass the white triangle mark. The patient, the family, and all the healthcare professionals need to be instructed to not lift the CDU above the level of the patient's chest and not to tip over the CDU. In this CDU, the red bellows are expanded and therefore the system is on suction. Theoretically, the intrapleural pressure is +2 in the column of the pleural pressure indicator, minus 20 amount of suction in CDU equal minus 18. However, if suction is disconnected, as indicated by the bellows non-expanded, it is possible to read a more precise intrapleural pressure, which in this case and in this moment is about minus 14. Therefore, a more precise intrapleural pressure is read off suction. When the CDU is off suction, you can study the amount of oscillation of the water in the pleural pressure column, so-called tidaling, which gives information about the chest tube patency, the presence of air in the pleural space, and the respiratory effort. Tidaling stops when the chest tube is blocked, so-called dead tube. If the tidaling amplitude is excessive, this usually indicates the persistence of some intrapleural air and a low negative pressure. In this case, can be useful to reapply suction and keep the chest tube longer. Every morning during patients' rounds, it is important to check the orange bellows, check the amount of wall suction, check the amount of CDU suction, check the intrathoracic pressure when the system is off suction, check the level of water in the water-sealed chamber when the system is off suction, check the drainage level in the collecting sections, check the tube connections, and check the integrity of the retaining tapes and stitches. From an European and North American survey, most surgeons stop suction and remove the chest tube in less than 4 days after any type of lung surgeries. After chest tube insertion, the suction is usually stopped within 1 day or 2, or less, and the chest tube removed if there is no air leak, or pneumothorax and the drainage is less than about 200 milliliters a day and does not look cloudy or infected. If in doubt, it is necessary to take a sample of the drainage from the tube and culture it. There is some debate if the chest tube needs to be removed during inspiration or expiration. The study showed that there is no difference in the rate of post-removal pneumothorax. We favor the quick removal of the chest tubes of suction during deep inspiration and Valsalva maneuver. During removal, a second person press on the chest tube tract and gentle massage it to collapse it. The vertical mattress suture, previously placed in the middle of the incision at the time of insertion, is now tied and the hole covered with Vaseline gauze. If a small pneumothorax is visible on the post-pull chest X-ray, the patient is placed on 100% oxygen, but if the pneumothorax is moderate or large in size, a new pigtail catheter is placed under CT guidance. After removal of the chest tube, a chest X-ray is frequently done, especially in academic centers, since a pneumothorax is possible even in the most expert hands. The patient is to be observed clinically. In some patients who are poor surgical candidate, a recurrent pneumothorax and/or recurrent and persistent effusion can be treated by sclerosing in the pleural space with irritating substances like doxycycline or talc. In these patients, the goal is to eliminate the pleural cavity with reactive adhesions. Spontaneous pneumothorax may occur in normal lungs or in patients with emphysema from rupture of a bulla or bleb. If small, it can be observed with serial exams, but if larger than small and clinically significant, it needs to be drained. Video-assisted thoracoscopy wedge resection of the air leak area is indicated when the air leak lasts more than a few days, or is recurrent, or the patient has been already surgically treated on the opposite side. In those patients where conservative measures are preferable, doxycycline or talc can be tried to control the air leak. This picture illustrates the placement of a small pigtail catheter and connection to a pneumostat. A postoperative air leak is not uncommon after lung resections and is usually self-limiting when originating from the parenchyma. A large and persistent air leak may be due to the presence of a true bronchopleural fistula and may need revision of the bronchial closure. A system problem in the chest tube or the CDU needs to be ruled out before considering a reoperation. A postoperative air leak tends to prolong the hospital stay, the patient discomfort, and the healthcare cost. At surgery, a meticulous technique may reduce its incidence. Progel is useful in reducing air leaks after lung surgery. It should be applied on surfaces as dry as possible in order to increase its adherence. Air leak that persists more than 5 days in surgery can be watched as small or moderate. Changes in suction in either direction can help, The patient can often be discharged home with a Heimlich valve and the chest tube removed later as an outpatient. However, large air leaks usually need to be re-explored and sutured. Dr. Heimlich invented the unidirectional valve and is also credited for the Heimlich maneuver. The Heimlich valve was introduced in 1968. More than 23,000 are sold each year. It is a flutter valve that opens in only one direction. Therefore, it is important to orient it correctly to prevent a tension pneumothorax. It can connect the chest tube to different kinds of drainage bags or can be left between gauzes if the lung is already adherent to the chest wall and an air leak persists. The valve allows to discharge the patient with a persistent air leak early after surgery as long as the chest X-ray does not show a pneumothorax when off suction. This review by a University of Alabama group shows that prolonged air leaks are more frequent in steroid use, male gender, a large leak, a leak with a pneumothorax, and having a lobectomy. Discharge with a Heimlich valve is usually safe and effective for persistent leak less than level 5. Most air leaks will seal in 2 weeks. If not, the chest tube was clamped for a day and removed if chest X-ray didn't show a pneumothorax. The same group suggested the alternative treatment of air leak persistent at the postoperative number 7 with the talc pleurodesis. We tend to use talc only in those patients in whom we are not planning any reoperation in the future, since it tends to create very intense adhesions which would increase the risk of a reoperation. A pneumostat is a small collecting chamber with a unidirectional valve that has a function similar to the Heimlich valve and can be easily drained when full. First-generation cephalosporin may reduce the incidence of an empyema after chest tube insertion, especially in the trauma setting. The term empyema tube refers to a chest tube left for a prolonged amount of time, usually after an empyema, a decortication, and still having purulent drainage and/or a prolonged air leak. A positive culture of the drainage may indicate the need for an empyema tube. The tube can be connected to a unidirectional valve and a bag, or left open to air if there are adhesions of the lung to the chest wall. The tube is then removed inch by inch once a week, so the tract will collapse slowly while still draining in the tube and heal without formation of pocket of empyema. In case a chest cavity will continue to be infected and the empyema is not resolved after decortication and chest tube drainage, an LOSR flap and intrathoracic vacuum-assisted sponges can be used to expedite the healing of the infected cavity. Thank you for watching these 3 presentations. I hope that you have enjoyed these talks and now have a clear understanding of the chest and pleural physiology, the chest tubes, and the chest drainage units. Thank you.